Ocular examination techniques. First we'll discuss about objective methods of refraction and subjective methods of refraction. In objective methods of refraction we'll discuss first about retinoscopy or skioscopy or shadow test. Retinoscopy, skioscopy, also known as shadow test. It is an objective method of finding the refractive error by the method of neutralization, by the principle of neutralization. Here normally a plane mirror is used in patients with hazy media and high degree of ametropia. Concave mirror can be used. Concave mirror is more useful. Normally plane mirror is used. Movement of red reflex when a plane mirror is used at a one distance of 1 meter, that is what we are looking for. If there is a movement of red reflex when a plane mirror is used at a distance of 1 meter. If there is no movement, then it is suggestive of myopia 1 diopter. No movement, then myopia of 1 diopter. With the movement along with the retinoscope, then with the movement, then emetropia or hypermetropia or myopia of less than 1 diopter. If it is the movement is opposite to the movement of against the movement, if movement is opposite to the movement of retinoscope, then myopia of more than 1 diopter. This is with the movement. This is a reflex. The retinoscope reflex, and there is a light reflex from the eye. If it is with the movement, then it will be emetropia or hypermetropia or myopia less than 1 diopter. If it is movement is opposite, this is a retinoscope reflex and the corneal reflex is the retinal reflex is opposite, then myopia of more than 1 diopter. Neutralization, either no movement, myopia of 1 diopter. Against the movement, myopia of more than 1 diopter. If there is a swirler and shadow, then it is suggestive of astigmatism, or cross, it is suggestive of astigmatism. Next objective method of refraction is autorefractometry or optometry. Here it is to find the refraction using refractometer or optometer. Then next is keratometry or ophthalmometry to estimate corneal astigmatism. Astigmatism by measuring the curvature of center of cornea. Optometry or ophthalmometry, it measures the corneal astigmatism by measuring the central curvature of the cornea. Then next is next objective refraction can be done by photorefraction. It measures measurement of refraction in both eyes simultaneously using infrared camera at a distance of 1 meter. These are the methods of objective refraction. Now coming to that is retinoscopy, autorefractometry, keratometry and photorefraction. Next is subjective methods of refraction. In subjective methods of refraction, we have subjective verification of baseline refraction, subjective refinement of refraction and subjective binocular balancing. Now subjective verification of baseline refraction, subjective refinement. In refinement, we can refine the cylinder and the sphere. Refining the cylinder, we use Jackson cross cylinder test. It is for verification of strength and axis of cylinder. Jackson cross cylinder, strength and axis of cylinder, and astigmatic fan test, inopic slit test. In for refining the sphere, we can use fogging technique, diachrome test and pinhole testing. Then there is subjective binocular balancing. That is about methods of refraction. Now next, perception. Visual perception is a complex integration of light sense, form sense, contrast sense and color sense. In visual perception, in light sense there is awareness of light. Form sense, it is basically visual acuity. Form sense is visual acuity. Here cones play a major role. Color vision is also a function of cones. In dim light, all colors are seen grey. Then this phenomenon is called Purkinje shift. Okay. Now visual acuity. Coming to visual acuity, distant visual acuity, we usually use Snellen's chart, that is at a distance of 6 meters or 20 feet. Okay, 20 feet or 6 meters. Logmar chart, that is Bailey-Love chart. Bailey-Love chart. Sorry. Bailey chart. Then landlord C chart for illiterate patients. This is the landlord C chart for illiterate patient. This is for illiterate. Then E chart is also for illiterate patients. There is a E chart here for illiterate patients. Then next is neovisual acuity chart. Here there can be Jaeger's chart, Roman test types. Then Snellen's also has neovision. Snellen's neovision test types. Visual acuity is a measure of spatial resolution of eye. Okay, spatial resolution of eye, or its ability to discriminate between 2 points. Visual acuity in case of special cases. In special cases like cataract, we can use a laser interferometry or potential acuity meter. In young children, that is less than 2 years, we can use visually evoked potential. Potential. Other tests for children are other tests include Keeler-Elliott and K-Pitcher test, then Cardiff acuity test. This is a Cardiff acuity test. Cardiff acuity test or Fuchs symbol test. Then preferential looking test can be used in other tests that can be used in children. Then Teller acuity cards are used in very young preverbal children, that is 1 to 3 years. These are the Teller acuity cards. These are the Teller acuity cards. This is a Cardiff test. This is the Teller acuity card. And then optokinetic nystagmus is objective measure of visual acuity. It is used in uncooperative patients or malingering patients. This is a optokinetic nystagmus drum. Next, photostress test. It is performed by covering one eye. It is performed by covering one eye and asking the patient to read the smallest possible line on near chart. Then a bright light like this is shown to one eye into the eye for 15 seconds, following which the patient is asked to read the same line of print and the recovery time is noted. In normal people and those with optic nerve disease, there is no difference in the time taken for the two eyes to recover from the photo stress. In macular diseases, this recovery time is prolonged. Test is useful in macular disease, particularly central serous retinopathy. That is photostress test for macular disease. A bright light is shown into the eye for 15 seconds, following which the patient is asked to read the same line of print and the recovery time is noted. Okay. Now, contrast sensitivity, we use a Pelly-Robson chart. This is a Pelly-Robson chart. Then Regan chart and sinusoidal pattern gratings. This is the sinusoidal pattern gratings. Now, next is test for color vision. For color vision, we can use Edrich Green Lantern test or Holmgren's Wool's test. Then Farnsworth Munsell 100 Hood test. This is the Farnsworth Munsell 100 Hood test. Then isochromatic chart, that is such as the Ishihara, Hardy, and Ritter charts can be used. Then anomaloscope, Nagel and Pickford Nicholson can be used. Next, test for malingering of color blindness. Convex lens test can be used. Prism base down test, prism base out test, and Snellen's color type test can be used. Then a lensmeter, or phosimeter or vertometer. These are same thing. Lensmeter, lensometer, phosimeter, vertometer. It is used to verify the correct prescription of a pair of glasses. It should be properly oriented and mark uncut lenses, and to confirm the correct mounting of lenses in spectacle frames. It will be you would have seen it in OPD. This machine is there. It is used to verify the correct prescription in a pair of glasses. Next, coming to field of vision. Field of vision, there is confrontation test and perimetry. Perimetry, there is kinetic perimetry and static perimetry. Kinetic perimetry, there can be it can be confrontation method, Lister's perimetry, tangent screen, scotometry, and Goldman's perimetry. These are the examples of kinetic perimetry. That is kinetic. There is like the stimulus will be moving. Static perimetry, the stimulus is fixed. It doesn't move. It it includes automated perimetry, Friedman perimetry, and Goldman perimetry. Next is peripheral field charting and central field charting. Now, for peripheral field charting, we can use confrontation method, Lister's perimetry, Goldman's perimetry, and automated perimetry. In central field charting, campimetry or scotometry can be used, or Goldman perimetry, or automated field analysis. In central field charting. Now next is coming to Amsler's grid. Amsler grid, the Amsler grid evaluates the 20 degree of the visual field centered on fixation. It principally useful this Amsler grid. It principally uses the useful in screening and monitoring of macular disease. There will be metamorphopsia, macular disease. Then it also demonstrates central visual field defects originating elsewhere. I have done a video on Amsler chart. That there are 7 different types of charts. Amsler chart. I'll put the link in description box. If you want, you can watch it. Then next is test for binocular vision. Test for binocular vision. Bagolini striated glass test is there. Polarized projectors, synoptophore and Wirtz 4 test is there. In Wirtz 4 test, in right eye. Wirtz 4 test, in normal binocular single vision and abnormal retinal correspondence, we will see 4 lights, and in case of right suppression, then 3 green lights will be seen, and left suppression 2 red lights will be seen. In case of diplopia, 5 lights will be seen, that is 2 red and 3 green. Right suppression, okay. That is Wirtz 4 test. Cornea. Coming to shape or curvature of the cornea can be determined by keratometry and corneal topography. Corneal thickness, it is measured by pachymetry, and corneal endothelial cell count is measured by specular microscope. These are different machines. It will be there in a OPD. You can go and see. Surface of cornea can be measured by biomicroscopy, window reflex test, and Placido disc test. This is a Placido disc test. Here we can see normal. We can see through the. So there is a instrument where we can see through the hole, and we can see this curvature, circles in the cornea. If there is inferior steepening, then there will be the curvature will become close together, and then irregular cornea. You can see here irregular cornea. The curvatures are irregular. Now then aesthesiometer is for quantification of corneal sensation. Now biomicroscopic examination after staining of cornea with vital stains. For fluorescent staining, there is area of denuded epithelium appears brilliant green. Bengal rose, it stains the disease and devitalized tissues. Vitalized cells red. Alcian blue stains excess mucus, as in keratoconjunctivitis sicca. Fluorescent staining, area of denuded epithelium appears brilliant green. Bengal rose stains the disease and devitalized cells red, and Alcian blue stains excess mucus, as in keratoconjunctivitis sicca. Now next is gonioscopy. Gonioscopy is the examination of angle of anterior chamber with gonio lens. Gonioscopy, and it can be direct or indirect. Direct gonioscopy examples include Cope, Birken, Wurst, Van Jacob and Richardson. Indirect include Goldman, Sees, Posner and Sussman. Next is tonography. Tonography is a non-invasive technique for determining the facility of aqueous outflow. That is tonography. Okay. Next, tonometry measures IOP. There can be 2 types: indentation tonometry, Schwartz, that is a Schwartz tonometry. This is a Schwartz tonometry. It indents the cornea. It has to indent the cornea. This is a Schwartz tonometry. Or applanation tonometry, that is based on Imbert Fix principle. There are different types: Goldman tonometry, Perkins tonometry, pneumatic, pulsar and tonopen. These are the applanation tonometers. Next, coming electrophysiological test. First we will discuss about electroretinogram. Electroretinogram, it records the changes in the resting potential of the eye induced by flashes of light. Induced by a flash of light. Changes in the resting, records the change in the resting potential of the eye induced by a flash of light. Now in normal cases, dark adapted eye after a fleeting early receptor potential, there are three components are seen. One is a wave. This is a wave. It is a negative wave, as you can see. It is a negative wave, and wave possibly arising from the rods and cones. This is a rods and cones. So A wave arises from the rods and cones. B wave is a large positive wave. Here this is a B wave. It is a large positive wave. It is generated by the Muller cells and the bipolar cells. B you can remember B wave from bipolar cells. Then C wave is also a positive wave. This is a C wave. It is a positive wave and it is a metabolic activity of the, see you can see it is a metabolic activity of the retinal pigment epithelium, that is C wave. Now uses of this ERG is functional abnormalities of the outer retina, that is up to the bipolar cell layer, here up to the bipolar cell layer, this up to the bipolar cell layer. Much before the ophthalmic signs appear, you can distinguish, like you can know the functional abnormalities of outer retina up to bipolar, okay, up to bipolar cell layer. Next, ERG is normal in disease involving ganglion cells and higher visual pathways, so like optic atrophy. Like if it involves a ganglion cell or then higher visual pathway like optic atrophy, then the ERG will be normal in these cases. Then next function is to assess retinal function when fundus examination is not possible, like cases of dense cataract, corneal opacity, in those cases. Then to assess retinal functions in babies when possibilities of impaired vision is considered, then you can do an ERG. Now abnormal ERG response, like supernormal responses are seen in case of, that is large A and B wave. This A and B wave is large, is seen in case of siderosis bulbi and albinism. Then subnormal response, that is B wave response is distinguished. B wave distinguished is seen in case of early cases of retinitis pigmentosa, okay. Subnormal response. Then extinguished response is that is complete failure. A complete failure of rods and cones function. An example in case of advanced retinitis pigmentosa, then complete retinal detachment, and CRAO and advanced siderosis. In these cases we can see a extinguished response. The negative response is usually seen in case of gross disturbance of retinal circulations like CRAO and CRVO. Next, electrooculogram. Electrooculogram is based on the measurement of the resting potential between the cornea and the retina, that is see here cornea is positive, having a resting potential of positive, and retina is negative. This EOG is a measurement of the resting potential between the cornea, that is positive, and back of the retina, negative. Electrodes are placed over the orbital margin near the medial and lateral canthus. Here you can see electrodes are placed. Normally the resting potential of the eye decreases during dark adaptation and it peaks in light adaptation. So results of EOG are interpreted by finding out the Arden ratio. This is the Arden ratio. Arden ratio is maximum height of light peak divided by maximum height of dark trough into 100. See here this is a dark trough and this is a light trough. The maximum height of light peak divided by the maximum height of dark trough. This is a graph of standard graph of when lights off, the lights on. This is a lights off and lights on graph of EOG. This ratio is taken for normal in normal curve ratios more than 185. This you should remember, more than 185. Subnormal curves is when the ratio is less than 150, and flat curves is when the ratio is less than 125. Now uses of EOG. Uses include EOG reflects the presynaptic functions of retina. That is any disease which interferes the function between the interplay between RPE and photoreceptors will produce abnormal EOG. EOG is affected in disease such as retinitis pigmentosa, vitamin A deficiency, retinal detachment, and toxic retinopathies. Normal ERG with abnormal EOG, that is normal ERG and abnormal EOG is seen in cases of chloroquine toxicity and siderosis bulbi, okay. Normal ERG with abnormal EOG. Next we will discuss about visually evoked response. Visually evoked response is a EEG recorded at the occipital lobe. Now VER is the only clinically objective technique available to assess the functional state of the visual system beyond the retinal ganglion, beyond the retinal ganglion cell. Okay, that is the only test available to test the function of the visual system beyond the retinal ganglion cell, that is towards the occipital lobe. And then visual cortex, basically pattern flash VR. Two types are there, flash VR and pattern reversal VR. Flash VR, actually more types are there. You should know flash VR and pattern reversal. Flash VR merely indicates that light has been perceived by the visual cortex. It is not affected by the opacities in the lens and cornea, and assess the integrity of the macula and visual pathway in infants, mentally retarded and aphasic patients. Then distinguish between organic and psychological blindness, that is malingering and hysterical blindness. We can distinguish. It can detect visual potentials in eyes with opaque media, that is already told. Then pattern reversal is this is a pattern reversal. See, you can see the pattern is reversed here. White becomes black, black becomes white. There is a pattern reversal VR. It depends on form sense. And thus may give rough estimate of visual acuity. Then VR is fully established at 6 months. To confirm, it can usually be used to confirm optic nerve diseases like retrobulbar neuritis, retrobulbar disease disorders. It is usually used for that. Next, coming to ocular ultrasonography. It usually ultrasonic frequencies in the range of 10 megahertz are used for ophthalmic diagnosis. Now A scan is also known as a time amplitude. It is the distance between the two echo spikes, provides an indirect measurement of the eyeball length or anterior chamber depth and lens thickness. Two spikes will give an approximate distance between the anterior chamber depth, indirect measurement of eyeball length, anterior chamber depth and lens thickness. Now height of the spike indicates the strength of the tissue. Height indicates the strength of the tissue, sending back the echo. The corneal lens and sclera produce very high amplitude spike, while the vitreous membrane and vitreous hemorrhages produced very low spike. Vitreous hemorrhage and vitreous membrane. Uses of the measurement uses of A scan include axial length and mainly for IOL power calculation, biometry. Then depth of anterior chamber, thickness of intraocular mass. For these things A scan can be used. B scan is intensity modulation. It is the assessment of posterior segment in presence of opaque media. Basically for posterior segment assessment in case of opaque media, we can't see through by using fundus or slit lamp biomicroscope, so we can use a posterior B scan ultrasonography. It is study of intraocular and orbital tumors and other mass lesion. Then localization of intraocular and intraorbital foreign bodies, then tumor, for all these things we can use B scan ultrasonography, posterior segment. Next, techniques of fundus examination. Now we can there is ophthalmoscopy and slit lamp biomicroscopy. Ophthalmoscopy can be distant direct ophthalmoscopy or a direct ophthalmoscopy or indirect ophthalmoscopy. It can be distant direct ophthalmoscopy, direct ophthalmoscopy or indirect ophthalmoscopy. Slit lamp biomicroscopy can be indirect, that is or Ruby lens can be used, in contact lens biomicroscopy is there. Indirect, first we will discuss about indirect slit lamp biomicroscopy using +78 or +90 diopter, small diameter lenses used. Most commonly employed technique for biomicroscopic examination of posterior pole of fundus, slit lamp biomicroscopy. Then Ruby lens biomicroscopy, it is a plano-convex lens, okay, plano-convex lens with power of 58.6 diopter, 58.6 diopter, plano-convex lens, 58.6. Then next is direct ophthalmoscope. Direct ophthalmoscope, it is most commonly, this direct ophthalmoscope is the most commonly practiced method for routine fundus examination. It distance from the patient, we will go from distant like this, then will go from distance to as close to the patient, as close as possible. Then characteristic of the image is formed in direct ophthalmoscope, or it is erect, virtual, and 15 times magnified in immotropes, more in myopes and less in hypermetropes. Okay, magnification is more in myopes and less in hypermetropes. Area of the field of focus is about 2 disc diopters. Not useful in AC media, and stereopsis is absent because we are using only one eye. Now next is distant direct ophthalmoscope. Here light is thrown into the patient's eye at a distance of about 20 to 25 centimeter. Applications is to diagnose opacity in the refractive medium, like there will be a dark shadow in a red glow, or to differentiate between a mole and a hole of iris, to recognize mole and hole of iris. There will be transillumination through the hole. Then to recognize detached retina or tumor arising from the fundus, there will be greyish reflex in those cases. Tumors or retinal detachment or a tumor, there instead of red reflex there will be a greyish reflex. Then next is IDO, indirect ophthalmoscope. Here the distance from the patient is at arm's length. We will examine the patient. Characteristics of the image is, here it is real, inverted, and magnification is 2.5 times, that is with plus 20 diopters it is 2.5 times, real and inverted. It is 8 disc diameter in focus. Then peripheral retina up to ora serrata is visible. Okay, in peripheral retina up to ora serrata is visible. Useful in hazy media, it can be used in hazy media. Stereopsis is present with binocular indirect ophthalmoscope. Depth of perception of lesion is possible. Depth perception is possible. Next, coming to fundus fluorescent angiography. See, fundus fluorescent angiography, there is a detailed video I have done. I will put the link in the description box. If you want, you can watch it. This is just superficially we are discussing now. The fluorescent dye injected into the antecubital vein after the pupils are dilated. Now fundus photographs are taken first picture after 5 seconds and last after 10 minutes. Okay, abnormalities detected in FFA. Abnormalities are either hyperfluorescence or hypofluorescence. Hyperfluorescence, window defect in RPE due to atrophy will be seen. Window defect in RPE indicates atrophy. Pooling of dye under detached RPE is seen in ARMD. Here pooling of dye is seen in ARMD. The detached RPE, there is in detached RPE there is pooling of dye, known as, this is a pooling of dye, that is seen in ARMD. CSR, again there is pooling of dye due to breakdown of blood retinal barrier. Pooling of dye under sensory retina due to breakdown of blood retinal barrier in CSR. Then in cystoid macular edema there is leakage of eye. Leakage of dye into the neurosensory retina, again due to breakdown of blood retinal barrier. Then in proliferative diabetic retinopathy and ARMD later stages also there will be leakage of dye from choroidal or retinal neovascularization. Okay, or retinal neovascularization. Then staining of the dye is seen in case of drusen. There is long retention of dye and also leakage of dye from optic disc, optic nerve head. Like in papilledema, there will be leakage of dye from optic nerve head. Now, hyperfluorescence, causes of hyperfluorescence. There is blockage of in retinal hemorrhages, hard exudates and pigment clumps. There will be blockage of fluorescence. Blockage. Here there is a blockage, like because of it can be because of retinal hemorrhage. The underlying fluorescence is not visible. Blockage of fluorescence can be present. Blockage of background fluorescent due to abnormal deposits on the retina, like retinal hemorrhages, hard exudates and pigmented clumps. Then occlusion of retinal or choroidal vasculature can be seen in occlusion of choroidal and retinal vasculature is seen in CRIO and diabetic retinopathy. Loss of vasculature will lead to seen in loss of vasculature is seen in chorioderma and myopic degeneration. Here we can see loss of vasculature. Next is mydriatics and cycloplegics. Like there are different drugs like atropine sulfate, homotropine, cyclopendyl, tropicamide and phenylephrine. This This tropicamide and phenylephrine have only mydriatics action. Other three are they have both mydriatic and cycloplegic action. This atropine sulfate is the more fun. It's available in 1% ointment, and it's the most powerful cycloplegic agent. Used in less than 5 years. It is the longest acting, 10 to 20 days, and retinoscopy is done after 4th day. Homatropine is 2% eye drops. Cyclopentolate 1%, tropicamide again 1%, and phenylephrine 5%, 10% drops. Homatropine, the duration of action is 48 to 72 hours, that is 2 to 3 days. And retinoscopy is done after 90 minutes, or almost 1.5 hours. Cycloplegic again 6 to 18 hours, retinoscopy is done after 1.5 hours. Then tropicamide and phenylephrine used only as mydriatics. We can't do retinoscopy in them.